Good afternoon, everyone, and welcome to today's Public Health Ontario's Microbiology Rounds presentation on A Step Toward Understanding Neovaginal Health for Trans Women. My name is Angela Ma. I'm a clinical microbiologist at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I will mention a few housekeeping items. Firstly, the chat pod has been disabled to limit any distractions during the presentation. To our audience members, please use the Q&A pod if you have questions during this session. A discussion and question period will follow the presentation. If at any point during this session you experience any technical issues, please email capacitybuilding@oahpp.ca. Lastly, I would like to state as the moderator of this session that I do not have any conflicts of interest. It is now my pleasure to introduce the speaker for today's presentation, Dr. Jessica Prodger. Dr. Jessica Prodger is an assistant professor of microbiology and immunology and director of the Global Health Systems Master of Health Sciences program at Western University in Ontario, Canada. She received her PhD from the University of Toronto and completed postdoctoral fellowships at the Johns Hopkins School of Public Health and at the Laboratory for Immunoregulation at the National Institutes of Health. She holds a Tier 2 Canada Research Chair in Genital Immunology and STI Prevention, and her research program at Western focuses on understanding how genital microbiota influence local host immune responses and thus susceptibility to pathogen genital infections. So without further ado, I'll pass on the presentation to Dr. Prodger for her to take it away. Thank you very much.
Thanks. Thank you very much for that welcome. I'm really excited to be here talking to you all a little bit about the steps we've made recently towards understanding neovaginal health for trans women. And this work is very much a collaboration between myself and microbial ecologist Jacques Ravel, who's at the University of Maryland. I'd like to start with a land acknowledgement. So I'd like to acknowledge that Western University is located on the traditional lands of the Anishinaabe, Haudenosaunee, Len Apaiwak, and Chinooktun nations. And I respect the longstanding relationships that Indigenous nations have to this land, as they are the original caretakers. We acknowledge historical and ongoing injustices that Indigenous peoples endure in Canada, and we accept responsibility as a public institution to contribute towards revealing and correcting miseducation, as well as renewing respectful relationships with Indigenous communities. For disclosures, I have no financial conflicts of interest relevant to this work to disclose, but I would like to disclose that the work I'm going to be presented was supported by funding from Western University, the Canadian Institutes of Health Research, NIH in the United States, the Canadian Foundation for Innovation, Administrative Colleges of Universities, which is the Ontario government, and the Canada Research Chair Program. So I'm hoping that by the end of the hour, you will be able to describe the microstructure of the neovagina, which is created by penile inversion vaginoplasty, that you will understand how the neovaginal microbiome differs from natal, vaginal, and penile skin, and that you've gained some insight into which neovaginal bacteria might be beneficial and which might be problematic or associated with inflammation. And also understand why the best practices, diagnostics, and treatments that have been designed using data from the natal vagina of cisgender women can't be just directly applied to the neovagina. So I want to start by just talking a little bit about terminology that I'm going to use. And this is a photo of my son when he was 3 years old in daycare, and he very much, to my joy, loved to correct his daycare workers when they would try to tell him that boys have penises and girls have vaginas. And so when your sex does match your gender, I'm going to refer to this as cisgender. When your sex differs from your gender, I'll refer to this as transgender. And if your gender isn't entirely masculine or feminine, or if your gender may vary between masculine and feminine, I'll refer to this as non-binary today. So gender affirming medical care is medical care that someone can receive that will help to produce physical traits that better match their gender. And this can be really important because when your physical traits don't match your gender, this can cause gender dysphoria, anxiety, depression. It can impact your sexual functioning and your quality of life. And so gender affirming medical care generally falls into two broad categories biologically, which is surgeries, things like breast reduction or augmentation, vaginoplasty, which is what I'm going to be talking about today, orchiectomy, removal of the testes, or hysterectomy. And or it can fall into hormone therapy. So for transmasculine individuals, this would be masculinizing hormones like testosterone. And for transfeminine individuals, this is generally estrogen and also potentially testosterone blockers if they haven't had orchiectomy. Okay, so moving into the microbiome and the genitals. The genital microbiome we know is very key to sexual and reproductive health. And the largest body of evidence we have for this is really from the cis female vagina. And a big one is bacterial vaginosis. So bacterial vaginosis is a symptomology, including discharge, malodor, bleeding, things like, discharge, malodor, itching, things like that. And bacterial vaginosis is caused by a disruption in the vaginal microbiome when there are low amounts of a bacteria called lactobacillus. And instead, these lactobacillus is replaced by diverse anaerobes. And the symptoms are really problematic. They result in a huge number of doctor visits and can really, of course, impact quality of life for the people experiencing them. But in addition, the microbiome does a lot more than cause these symptoms. It can have some very serious gynecologic outcomes like pelvic inflammatory disease. It leaves you at higher risk for sexually transmitted infections like herpes, HIV, or chlamydia. And also obstetric outcomes. So it can impact fertility, preterm delivery and birth weight, premature rupture of membranes, and a number of other obstetric complications. And interestingly, and I'm going to talk about this more in a couple more slides in the future, where I'll get into detail on the microbiome. These problematic gynecologic and obstetric conditions are not only seen when you have symptoms of BV. So the high risk for HIV, for example, is seen just as much in people who are asymptomatic as people who are symptomatic. And what they're really associated with is this change in the microbiota. This acquiring of these diverse anaerobes. Okay, so move over vagina. The penis also has a microbiome, and it turns out it is also important to sexual health. We just don't know as much about it because the changes in the penile microbiome are not associated with the same symptomology. So we've only found out more about them now that we're using molecular techniques to look at the bacteria that are there. And much like the vagina, if you have a high abundance of anaerobic bacteria on the penis, this is especially true when there's a foreskin underneath the foreskin. This can lead to chronic inflammation, just like in the vagina. And this is associated with an increased risk of STIs, prostate cancer, penile cancer, things like that. And we know that circumcision can reduce these anaerobes. And not only does it reduce the anaerobes, but it then, of course, decreases the risk of many of the pathologies that were associated with those. So taking a little bit of a deeper look at the bacteria in these two locations. Oh, sorry. These are stacked bar plots. So each of these vertical bars is representing one person. And then the color of those bars are representing the different bacteria that were found in that person's either vagina, and these are samples from 35 cis women, or underneath the foreskin from 56 cis men. So what you can see immediately is that most cis females are dominated by this bacteria that's red, which is lactobacillus, whereas the foreskin is much more diverse, but the most abundant bacteria here is this dark green one, which is Prevotella. And so both of these groups of individuals have been ordered based on decreasing abundance of that primary bacteria. And so over here on the right, you see the people with lots of red, they have lactobacillus domination. And what's actually going on here is that when there's higher levels of estrogen in the body, the vaginal tissue starts to make something called glycogen. And then lactobacilli take that glycogen and they use it as a food source. And when they chew it up to get energy out of it, the byproduct is lactic acid. And lactic acid excludes all other bacteria. So this monoculture that you're seeing in the vagina is actually really unusual. The vagina is this really interesting place when it comes to bacteria, because usually in ecology, diversity is the norm. So when the lactobacilli get disrupted for any reason, or they can't make lactic acid anymore, that's when you get these more diverse communities. So you're seeing over here things like Gardnerella, Adipobium, and also Prevotella seen in the penis. And these are more BV-associated anaerobes, and this is where you're getting the risk. In contrast, over here on the foreskin, you see things are much more diverse, but you can sort of split the underneath the foreskin into these two categories of bacteria. So these people over here that have less Prevotella, and this navy blue is a new genus that they've named Prevotella 6, like least exciting name ever. But anyway, so more Prevotella. And over here, there's more gram-positive or facultative or aerobic bacteria. And this is what's associated with decreased risk on the penis. And then over here on the right-hand side, that's associated with increased risk. Okay, so these two genitals have such different bacteria. And the reason why is because environment, just like plants, just like flora, the environment shapes what bacteria live in an environment. So if we're looking at reproductive age vagina of cis females, you can see this is a microscopy image. And so these darker things in the nuclei of cells, this is the outside of the body, like the vaginal canal, and this is the inside of the body. And you can see right away, this epithelium is much thicker in the vagina than over here on the penis. The vagina also has lower oxygen levels because, of course, it's a cavity and it's generally collapsed. This also means it has less water loss. And for most people who are born with a vagina, they're also born with a cervix, and cervix creates cervical secretions. So the vagina is bathed in cervical secretions, further decreasing any issues with water loss. In contrast, the penile skin is thinner, and it has to deal with variable oxygen levels and high water loss. And so what you get is this really tough outer layer of dead cells that don't have a nuclei that are called, it's called soft cornification, or some people call it keratinization, but I think soft cornification is a more accurate term. And this soft cornification is made up of what are called corneocytes, which are fully differentiated skin cells, and they're set into a lipid-rich extracellular matrix and bound together with these keratin bundles to make a strong and water-impermeable outer layer. And what this means is that these two epithelia have very different environments and very different nutrient sources for the bacteria that are there. So as I mentioned previously, in the vagina, it's these glycogen-rich cells that are sloughed off into the vagina that the bacteria had to eat. And then in penile skin, instead, it's free keratin proteins and fatty acids, so much more lipid-rich environment. Okay. So what about vaginoplasty, right? That's what we came to talk about. So vaginoplasty is the surgical creation of a vulva and a vaginal canal. And how that's done is the space between the rectum and the bladder is dissected, and penile and scrotal skin is used to make not only a new vaginal canal, but also outer and inner labia. The glands or the head of the penis is used to make a new clitoris, and then urethral tissue is used to make the new inner labia. Okay. So the result of this is that now we have a vaginal cavity that is lined with penile and scrotal skin. So to a woman with vaginoplasty, you have a super functional vagina and clitoris, but to a bacteria, this is somewhere between being in a vagina because there's low oxygen levels, less water loss, but you also have penile skin, and which raises the question of what food is there to eat. And so I'm going to take a break here, and we'll go. I guess we can say here are some questions that we sort of had as a mucosal immunologist, someone who's thinking about STIs and bacteria. My questions were, well, what is this microstructure of this epithelium, this neovaginal epithelium, going to be like? Women or transfeminine people who've had vaginoplasty are often on estrogen. Will that change? And now the skin is invaginated. Will this change the microstructure? Will it start to look more like the vagina, will retain those characteristics of skin. And of course, this leads to the next question: what would the colonizing bacteria be? Which bacteria might be beneficial or problematic in this setting? Because as we know, where a bacteria is depends on whether it's pathogenic or just a commensal. And of course, will diagnostics or treatments that have been decided for cis women work in the neovagina for trans women? And so I'm very excited to be working with the Women's College Hospital transition-related surgery team. They were strong advocates for vaginoplasty gaining an OHIP code in 2019 so that they could perform the first publicly funded or vaginoplasties at a publicly funded center. In September, they did their first solo vaginoplasty, and they're now doing more than 40 vaginoplasties a year. And this is photos of two of my colleagues there, Yona Krakowski, who's a urologist and surgeon, and Emery Potter, who's a nurse practitioner and is really heading the research program at Women's College Hospital. And I must say, makers of both beautiful vaginas and gingerbread houses. I just think that gingerbread house is totally amazing. Here I'm going to show you tissues. And these tissues were collected by Emery and my graduate student, Rhea Palmer. And first here, I'm showing you foreskin tissue from cis males who were undergoing totally elective circumcision, like for cosmetic or religious reasons. And then these are vaginal biopsies from reproductive aged females, cis women. And the first one's on the top here. This is H&E microscopy. So you can see that epithelium we saw before, but now we're staining for periodic acid shift, which is glycogen. So this bright pink color is all that glycogen. Now down on the bottom, this is the same sort of orientation of the tissue, but now it's using fluorescent markers. The blue are nuclei cells, just giving you the orientation. And then what we're staining for here in green is that soft cornified layer, specifically filigrin, which is one of those proteins in the bundles that kind of holds our skin together. So you can see nice bright green filigrin in the skin and totally absent from the vagina. So now I'm going to show you microscopy images from a trans woman who had vaginoplasty about 5 years before we took these samples. So what you can see, definitely no glycogen and still retaining that outer filigrin layer even 5 years post-vaginoplasty. I think not entirely exactly like from a histological perspective, the foreskin tissue, but if I had to, pick one that was different from the three, I think I would definitely be picking the vagina. And then from a nutrient perspective to the bacteria, that filigrin is still there and the glycogen is not there. Trans feminine people with vaginoplasty have BV-like symptoms. Either they never have those sorts of symptoms, so discharge, malodor, itching or burning, or they have them less often than cis women or more frequently than cis women. So to answer this question and many other questions that we had about the bacteria that were living there, I teamed up with Greta Bauer, who used to be here at Western University. She's now moved down to Minnesota. And of course, Jacques Ravel, who I mentioned earlier, who's a microbial ecologist at University of Maryland. And we did this study that we called TransBiota, which had a fully contactless design. We mailed out study kits to participants, and then participants would self-collect swab spreads for 3 weeks. They measured their own vaginal pH. They rolled swabs onto a glass slide for gram staining, and then they also collected swabs in DNA RNA shield for microbiome characterization, and then into the special buffer that we have for stabilizing proteins so that we could look at immune analytes that were there. And then with every time they collected samples for us, they filled in an online questionnaire. And then they mailed these samples back to us every week in a postage prepaid envelope. And through our recruitment period, we were able to recruit and obtain samples from 47 trans females who'd had vaginoplasty at least 1 year earlier. And we also did a study of trans men who were on testosterone, but I'm not going to be talking about those data today. So who are our participants? Our participants had an average age of 41 with a range of 23 to 69. Their average time since vaginoplasty was 4 years, but we had quite a big range of 1 to 19 years. About half of them were circumcised before they had their vaginoplasty. We had pretty poor, I would say, ethnic representation. Almost all of our participants identified as white. which may reflect, I think, who's accessing surgery. I'm not sure. And then we also asked participants a lot about their behaviors. So what are you doing with your vagina? And part of the reason why we asked this is because the recommendations from different surgical centers are very different. Some will say, everyone says you have to dilate post-surgery to maintain the opening of the vaginal canal. But there's different recommendations for how long you should carry on with that or how frequently it should be. Some centers say you absolutely should douche. Some centers don't recommend douching. And then there's other diverse exposures, which could be douching with commercially available liquids or using commercially available products or soaps inside the vagina. And so one of my previous students, Jason Halloran, and this is now published in the Journal of Sexual Medicine, found that people generally fell into 4 different sort of behavioral profiles. There were people who had minimal exposures, so they were not having sex either with sex toys or with flesh genitals. They weren't dilating, they weren't douching, they weren't using any products. Then there were some people who were only dilating as per their post-surgical recommendation, and this is always with lubrication, but different lubes. And then there were people who were both douching and dilating. And then there was a group of people who had about a quarter of the people who had more diverse exposures. And so that's the product use and things like that. Okay, so now answering the question about BV-like symptoms. So when asking about symptoms in the last week, so have you had symptoms in the last 7 days? About 3/4 of our participants had no symptoms at all. And then the other symptoms ranged across, of course, there were combinations of these, but bleeding, discharge, itching or burning, odor, and pain. And then the neovaginal pH, which I'm going to talk about in more detail, was a little bit higher than we generally see in the vagina. Okay, so what bacteria did we find there? So this data was generated by Bern Manari. They are a PhD student at the University of Maryland with shock. And so this is the same data I showed you before from the vagina and the foreskin. So here are the what we found in the neovagina. So these are a single sample from every one of our 47 transfeminine participants who'd had vaginoplasty. And what you can see, I think immediately when I see this, the first thing that I see is, okay, this is not a lactobacillus dominated environment. I see only very infrequently do I see red samples here representing lactobacilli. And I see a lot of the same dominant bacteria as are in the cis male underneath the foreskin. So these are all uncircumcised cis males. But there's definitely key differences here. There's a lot more streptococcus and a bacteria called Lawsonella and some other differences. So getting into those differences here, I'm just showing you a table with the top, I think, 20 bacteria, the genuses of bacteria in the neovagina. So this is their prevalence. So that tells you how many of our participants, what proportion of our participants had any number of those. So they could have even just one of those bacteria on their swab, and that's counted as being present. So 99.25% of our participants had, or our participant swabs, there was a total of 133 swabs collected. So 99% of those swabs had some Prevotella in them. And the median proportional abundance of Prevotella species, though, was 13%. So of all the bacteria that are there, 13% of them are Prevotella. Okay, and then over here, what I'm showing you is the median percentages in this underneath the foreskin, that CM is cis male, or in the natal vagina, CF is cis female. And what you can see right away is that the first 2 most abundant bacteria in the neovagina are shared with underneath the skin underneath the foreskin, and there's no significant difference between these numbers, not significantly different. And then lactobacillus down here, which is definitely but the most prevalent and abundant bacteria in the vagina, its proportional abundance is over 90% in the natal vagina, is present at 7% or 6% average abundance in the transfeminine neovagina or the underneath the cis male foreskin, and there's no significant difference there between it. And we found lactobacillus in about 60% of people, just at quite low abundance. But there are differences. So the neovagina is not exactly the same as the foreskin, as I mentioned. So things like Anaerococcus, Dialister, Escherichia are at significantly higher abundances in the neovagina compared to the foreskin. I'm just highlighting a few where there's big differences here. And then something like Feingoldea found at much lower abundance in the neovagina than the foreskin. Okay, so we've got this diverse microbiota. It's more like that of skin, and that of skin that is exposed to an anaerobic environment, like underneath the foreskin. What we did is we looked for correlations between the bacteria. The darker the red square, the greater the correlation. So those bacteria are both there at the same time, and then the number of them go up together with one another. And blue is that they're negatively correlated. So you see more of one, you see less of the other. And we did clustering, we used clustering methods on this to generally find four clusters of bacteria, or four groups of bacteria. So we're calling those taxa clusters, for lack of a more imaginative word, taxa clusters 1 through 4. And then when we looked at all those immune analytes, so those are markers of inflammation, we found generally that taxa clusters 1 and 2 were associated with higher levels of these pro-inflammatory cytokines, which we know in the vagina, when a bacteria causes inflammation, or on the penis as well, this is when it's associated with problems. But then taxa clusters 3 and 4 are actually associated with lower levels. So the more of those bacteria you have, the less inflammation you have. So potentially beneficial bacteria. Okay, and so when we then take our samples, so these are all 133 samples from the participants. Again, each bar is a person, but now they're colored based on the abundance of the bacteria that are in those taxa clusters. We can see that there are some people who have a much higher abundance of taxa clusters 1 or 2 that were associated with inflammation, and then, or a much higher abundance of taxa clusters 3 and 4 that aren't associated with inflammation. Okay, so to me, this raises still two questions. One is this inflammation actually associated with symptoms or negative health outcomes? And two, what can you do something, if to get out of the high inflammation group and over here to the low inflammation group? And I'll tell you in advance, spoiler alert, the short end of the story is that we're going to need larger studies with that are controlled to have more interventions to answer these questions, because people's behaviors were very diverse, as I mentioned previously. But we did take a look at this based on those 4 sort of groups of people. And there's a couple things I just want to point out here. So these are people who are dilating only, and people who are both douching and dilating. So the only difference between them here is the douching. And what you can see in terms of their abundance of taxa cluster 1, 2, 3, or 4 is that we never saw any differences between with the addition of that behavior of douching, which is interesting because in the natal vagina, douching is associated with really substantial changes in the bacteria that are not good changes, shift away from lactobacilli. We also saw in general sort of this trend of more of the taxa cluster 2, the inflammatory taxa cluster 2 bacteria, as you did more things, as you had more behavior, more diverse behaviors or exposures to the neovagina, and a significant decreases in the 2 less inflammatory bacteria. Now, I don't necessarily think that means that diverse exposures is causing these changes in the microbiome, is causing these inflammatory bacteria to be able to take over. It's possible, but it definitely needs to be proven with some temporality. Because of course, if you have a lot of neovaginal symptoms, you're more likely to be trying a whole bunch of different things to try to treat these symptoms. Whereas if you have no symptoms at all, you're probably not going to go to the store and buy something for that reason. Okay, so what about symptoms? So here, what I'm showing you is people who had no symptom at all, or no symptom at that visit, and then people who only had bleeding or only had discharge. And you can see there's a lot of sort of patterns here, but not a lot of significance in the bars on top. And I think the symptoms are diverse, and we simply need larger and longitudinal studies. But what we did really notice is that bleeding was associated with more of these taxa cluster 1 bacteria, and they are inflammatory. And so it does raise a question. Is this inflammation, are these bacteria caused by having blood, because this is a totally different nutrient source? Or is this these bacteria causing inflammation that's causing de-epithelialization of the neovagina and hypergranulation tissue, and that's when we start to see blood. The other interesting one that really popped out was malodor. So you can see malodor associated with much higher levels of the bacteria in taxa cluster 3, which were also associated with lower inflammation, which may mean, very unfortunately, that these bacteria that are sort of happy, the neovagina is happy having them inhabit it, also make stinky compounds, which would be sort of a bummer. And then another way to look at this is a principal component analysis plot. So this plot, very busy, but basically all it is taking all the diversity of the microbiome and putting it on 2 axes. So dots, each dot is a sample. And if the 2 dots are really far away from each other, then they're really different from one another. And you can see these black diamonds are samples where the participants said they had no symptoms in the last week. And they're kind of spread out all over the place. So there's a lot of different ways to have no symptoms, but there are fewer places you can be if there is bleeding. So basically, if you reported bleeding and any other symptom, malodor, pain, discharge, whatever, you were up here fairly tightly clustered in this one quadrant, which is informative. And then if you had malodor, you were clustered down here in this bottom quadrant, saying that, you know, it's probably a very specific set of bacteria that are making that malodor. And then here in the middle were people with both discharge and malodor, so maybe something sort of different going on there. Okay, so I'm going to take the last part of this session for the next sort of 10 minutes to talk about diagnostic tools for bacterial vaginosis, which is generally the AMSEL criteria. So when a transfeminine person comes to their, their primary care provider and they have symptoms that are BV-like, right now those primary care providers are probably using the AMSEL criteria on them. So AMSEL criteria, number 1, abnormal vaginal discharge. Okay, we see that in both vagina and the neovagina. That's probably why you're there. The second part of the AMSEL criteria is having a vaginal pH that is greater than 4.5. Okay, here are the pHs of all the samples taken in our study. And what you can see is most people are around 5.5, which would fall into a positive hit for this AMSEL criteria. But is that really a problem in the neovagina? And I might argue not. Down here is where you'd have to have a normal pH. And, you know, lots of these people, as you saw, don't have any symptoms at all, 75% of them. And up here, this is a normal pH of skin. Skin is actually a little bit acidic itself, just not as much as the vagina. It ranges from 4.5 to 5.5. So pH, probably not that helpful in identifying vaginas that have a bacterial imbalance. Okay, the next thing is having a fishy odor when the vaginal fluid is exposed to 10% KOH. Now, this specific method for detecting this fishy odor only detects biogenic amines, which are a main biogenic amines is like a volatile compound that bacteria, BV bacteria, make. And then, of course, that's released out of the vagina and it causes that odor. But the problem is that you can have lots of different odors all over your body, and most of them are caused by bacteria, but they're not biogenic amines. So stinky feet, usually caused by isovaleric acid or acetic acid that's caused by skin bacteria, does not smell like fish. Same thing with wound odor, sweat malodor. They each have their own unique smell that, you know, everyone is familiar with from being human. That's not fishy. And my graduate student, Ainsley Shouldish, she made these scent test kits where she dissolved all these cottons onto cotton swabs, put them in glass vials, and mailed them out to people from TransBiota who said they'd had malodor at some point in their life. And they would waft them, like sniff them, and say, oh yeah, that is definitely what my malodor smells like, or it's a little bit like that one, and rate them. And what she found is that there was a large diversity in malodor of people saying, yes, that is my malodor, between all these different compounds that are responsible for malodor around the body. And we did see some trimethylamine, but it definitely wasn't, you know, the most prominent one. So the fishy odor with KOH, probably not that useful. It only detects 1/6 of transfeminine participants' malodors. The last one is doing Nugent scoring, which is gram staining. Okay, so what's Nugent scoring again anyway? This study was done by Rhea Parmer, another graduate student of mine. And so what Nugent scoring is when you take a vaginal smear, you do gram staining, and then you score it. And what you're scoring it on is the presence or absence, very specifically, of 3 different bacteria, or bacteria that have the same morphology as those bacteria. So you're looking, we want to see lots of lactobacilli, that gets you a low score. You want to see few Gardnerella. If you see Gardnerella morphotype bacteria, you get a higher score, and curved bacteria, which is trying to look for Mobiluncus, gets you a higher score as well. If you 0 to 3, that means you have a normal. 4 to 6 is inconclusive. We're not really sure if BV is causing your symptoms, and 7 to 10 is the diagnosis of BV. Okay, so remember back to that correlation matrix. So let's look for the Nugent bacteria on there. Lactobacillus and Gardnerella don't even make the top 30 most abundant bacteria in the neovagina. They're very rare. And I'll just tell you, they had no association with inflammation when they were there. Mobiluncus down here, that's a gram variable curved rod. It was generally associated, it was prevalent in the neovagina, but it was generally associated with lower inflammation, so potentially beneficial. So now let's look at 2 of those groups that were really associated with high inflammation. This is taxicluster 1, and here's taxicluster 3. And both of these taxiclusters, totally different bacteria, but they're all composed of gram-positive cocci, gram-negative rods, and gram-positive rods. So I would say potentially, I mean, certainly based on Nugent score, indistinguishable, even though one is potentially very good and one is potentially very bad. And so just really hammering on that futility of Nugent scoring. Here on the left, I'm showing you gram staining from a neovagina for someone who had a very low inflammation microbiota, and their Nugent score ended up being 7. And then over here, someone who had a very high inflammation microbiota, and they also get a Nugent score of 7. And not surprisingly, almost everyone in our study gets a Nugent score of 7. It switches, a few lactobacilli and a few of these other bacteria. Okay, and so not only is everyone falling into one category, but let's talk about, just showing it quantitatively here. These are the different Nugent scoring outcomes, and you can see that people who have a really high abundance of those low inflammatory bacteria are actually have significantly more likely people who have a high Nugent score actually have significantly higher levels of those low inflammation bacteria. So it's almost misleading. And then it's completely non-informative in terms of identifying people with high abundance of those really high inflammation bacteria. And what about symptoms? Just like no correlation at all. There's no difference in Nugent score between people who do have a symptom and people who don't have a symptom. Okay, so in addition to AMSL criteria, some centers are starting to use sequence-based diagnostics for bacterial vaginosis. So for example, the hologic. But I just wanted to point out that what these are doing is they are now looking for sequencers, which is great, but they're doing targeted sequencing. So they're looking very specifically for 3 different lactobacilli, G-vag or Adipovium vaginae. And so all of these bacteria are very low levels in the neovagina. So this is not likely to be any more informative than the Nugent score was. The key takeaways from this talk, I think, or what I'm hoping the key takeaways are, is that the neovaginal epithelium does retain a skin-like microstructure even 5 years post-vaginoplasty. And we believe that this means that the bacteria that live there, or that even can live there, are going to be more skin-like, things that like eating fatty acids and proteins, because there's no glycogen there to feed lactobacilli. So the neovaginal bacterium is very different from the natal vagina, and it's also very diverse. There's a lot there, which makes it hard to do diagnostics by gram staining. There are distinct low and high inflammation communities, which is great. It gives us something to work at in terms of interventions in the future. But unfortunately, Nugent scoring and other BV diagnostics are just not useful at all. And I think also, I'm not a clinician, this probably calls into the question, the efficacy of which antibiotics you choose to try to eliminate what might be the inflammatory bacteria. So the efficacy of metronidazole is hinged on the fact that it spares lactobacilli. So it clears out the anaerobes that are there. Yes, that's great. But if it didn't spare the lactobacilli, if it also killed them, the anaerobes would have just as much of chance coming back is lactobacilli. But what it does is it eliminates the anaerobes and gives this chance for lactobacilli to regain their dominance. And that whole ecosystem is not happening in the neovagina. So I don't think that metronidazole is necessarily going to be the right choice. And then also what's determining the bacterial communities that are there, we do need longitudinal studies where we tell everyone like, okay, everybody stop using products, everybody start using products so we can actually get some clear data. But interestingly, from our very preliminary data, it looks like douching might be okay, not particularly specifically beneficial or problematic. But if it improves symptomology, it doesn't appear to be having a disruptive effect on the neovaginal bacteria. Okay, so with that, I just, of course, want to thank all my graduate students and the rest of my research team who was very instrumental in helping us set up TransBiota, Jacques Ravel's team, and especially Bern Manari and Pavel Geiger at the University of Maryland, and the team at Women's College Hospital. Really, Emery Potter has been just like such an amazing colleague to work with. So thank you very much for your attention.
Thank you so much, Jessica, for that amazing talk. It was such an interesting topic, and I personally learned so much. We are now going to move to the Q&A segment of this event to address some of the questions from our audience. Please continue to enter your questions into the Q&A pod if you have not already had the opportunity to do so. I'd like to start off with a question of my own, if that's okay. You had a lot of great information about BV, and microbiota and the changes to that in individuals that do have a neovagina. Has there been research through your own work or through your collaborations and those in the field about looking at other pathogens? I know you had mentioned that there's an increased risk of HIV possibly in some of these individuals, but is there any work that's been looked at into, say, increased susceptibility to parasites such as like Trichomonas vaginalis or other kind of common genital urinary pathogens that, whether it's cis females or cis males present with?
Yeah, we haven't started to look at those pathogens specifically. It's certainly something we're really interested in looking at. I can say in all of our gram staining, 133 slides, we actually originally had 136 slides, and it turns out we did see some yeast on some of those slides that were eventually discounted. And we thought, oh, this is so neat. Maybe there's yeast in the neovagina. Yeah, it turns out it was a cis female who snuck into our study. So in 133 swabs from transfeminine individuals, we did not see a single yeast. And I don't think that doesn't mean they're not important, but probably candida, not a major cause. In terms of HIV susceptibility, I think, there's sort of, if you look at global epidemiology of HIV, and I do a lot of HIV work as well. Transgender women are considered to be a key population, which means they would have like a higher risk of acquiring HIV globally. But I do not think, and from our study at least of transgender individuals across Canada, we did not see high risk behaviors. We didn't see people, a lot of people having high risk vaginal sex, unprotected vaginal sex, multiple partners. And I think more likely the global trends in higher HIV prevalence among trans individuals has to do partially with social determinants of health and potentially receptive anal intercourse. I'm not sure the neovagina as a mucosa is a really what is making trans women at higher risk for HIV. In fact, I really doubt it is. So we're certainly interested in looking into that, the possibility, especially for other sexually transmitted infections and pathogens. But I think people have conflated those two things, like, oh, trans women higher risk for HIV, trans women get neovaginas. So maybe there's a link between those, but I think they're totally separate from one another.
Thank you for that really informative and thorough answer. A question from our Q&A pod. Would you recommend PAPS post-vaginoplasty, which does not seem useful since there's no cervix, since GRS Clinic in Montreal still recommends them 12 to 18 months post-vaginoplasty with cavities?
Okay, so now I'll tell you about the biology behind this, and then you clinicians can tell me whether or not you think that the PAP is useful. So what I can tell you is a neovagina is still susceptible to HPV. And just like you can get HPV on the penis, and you get high-risk HPV on the penis, and you can get penile cancers as a result of HPV. So there's definitely HPV is still a possibility for the neovagina. Now, whether or not PAP is the right diagnostic for it, I think is a different question. So if you're doing like a sequencing based or like a PCR amplification or a gene-based test for shedding of high-risk HPV, definitely, I think that is something that trans women need to be thinking about.
Thanks for your answer on that. Another question from our Q&A pod. Assuming the cis female microbiome is from premenopausal women, and is that typically what you're seeing with your research and your participants? And then expanding on that topic, wondering if you have looked at how postmenopausal cis female woman compares to the premenopausal cis female woman or neovaginal, trans female neovaginal microbiomes.
Okay, so Jacques Ravel does, my collaborator in Maryland has done a ton of work looking at the natal vagina, both pre-menarche, so pre-puberty, through the reproductive age, through pregnancy, through menses, and post menopause. And post-menopause, you definitely see less lactobacilli. You actually start to see more, but you don't entirely see a BV-associated microbiome. You actually start to see more strep and some skin-like bacteria. And Jacques is still sort of working on how does that relate to symptomology that we sort of associate with postmenopause, like symptoms of vaginal atrophy or pain, itching, bleeding, fragility, things like that. So that's an interesting question. I would definitely say that the neovagina looks substantially more like, so we're doing an entire analysis, excuse me, on postmenopausal females, premenopausal females, and transmasculine individuals who are on testosterone. And their vaginal microbiota, because their symptomology can often be similar to postmenopause. And we are seeing similarities to postmenopause, but still distinct differences that we think is probably from the effect of the testosterone as opposed to just a lack of estrogen. So that analysis is forthcoming. And from looking at those postmenopausal women, comparing to, my transfeminine neovagina, I definitely don't see, I see some of the same bacteria there in terms of skin bacteria, but definitely the neovagina is more like other skin areas than like the postmenopausal vagina. I hope that was a really long answer. And part of the reason I suspect is because the postmenopausal vagina, although it loses glycogen as estrogen levels come down, it never becomes cornified. So you don't have those lipids and fatty acids and things like that I think are feeding the bacteria in other places.
Great, thanks for that amazing answer. Kind of seeing how you mentioned transmasculine in your answer, I was just curious, has there been similar work done for individuals who are having female to male surgery for the, bottom surgeries, whether that's, development of a penis and urethra or possibly for a defined phallus, and kind of there are differences in, where tissue is being used for that surgical procedure and, whether or not kind of there's work on microbiota as well for transmasculine individuals.
Yeah, we have not started looking at post-bottom surgery in trans men at all yet. That's definitely something that I think is very important, and STIs and things like that at that location. And I think also something that this reminds me that I'd really like to highlight is that all the data I showed you was for individuals who had had penile inversion vaginoplasty, which is currently the only form of vaginoplasty that's available in Canada. But there are centers in the United States that are using some peritoneum to get length of the vaginal cavity. They're pulling down peritoneum to get that back end length. Some people are using intestinal tissue for that. And so these of course, as I hope I hope everybody's with me on board, I imagine that these different tissues, these different epitheliums are going to provide a different environment for bacteria to live in and then have different bacteria. So everything you learned today really applies to people who had vaginoplasty in Canada or at another center in the world where penile is penile inversion.
Thanks so much for that answer. Seeing as we are just rounding up to the hour, I think this would be a good place to stop and wrap up today's PHO microbiology rounds. Again, I would like to thank you, Dr. Jessica Prodger, for your amazing presentation and for that Q&A session that was incredibly informative. I would like to also thank everyone who joined us for today's webinar. To our participants, you can expect to receive a brief and anonymous PHO microbiology round survey for today's session, and we please ask that you complete this to help us improve our programming. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. And lastly, thank you to everyone and have a wonderful day.